Welcome to the American College of Correctional Physicians, ACCP YouTube channel podcast, where we explore the evolving landscape of correctional healthcare with leading experts in the field. I'm Dr. Susan Rashid, a family medicine physician, and it is an honor to bring you insightful discussions on the challenges, innovations, and future of correctional healthcare. Today, I am joined by my esteemed co-host, Dr. Jeffrey Keller, the current president of the American College of Correctional Physicians. He is a leading voice in correctional medicine. Dr. Keller has been instrumental in shaping policies and practices that enhance the delivery of healthcare to incarcerated populations. Together, we aim to shed light on the critical and unique issues facing correctional healthcare professionals. We are privileged today to welcome our distinguished guest, Dr. Michelle Staples-Horne. With over 30 years of leadership as the medical director for the Georgia Department of Juvenile Justice, Dr. Staples-Horne has dedicated her career to ensuring high-quality health care for justice-involved youth. Under her guidance, Georgia's juvenile health care program has grown from a modest initiative into a nationally recognized model of excellence, serving over 1,000 youth daily across 25 secure facilities. Dr. Staples-Horne holds a medical degree from Morehouse School of Medicine, a Master of Public Health degree from Emory University, and training in both pediatrics and preventive medicine. She is a trailblazer in correctional health. She has served on numerous advisory boards, including the American Correctional Association, the Accreditation Council for Graduate Medical Education, and the National Commission on Correctional Health Care. She is also a former president of the American College of Correctional Physicians. Her contributions to the field have earned her the highest of honors, including the Armand Start Award from ACCP, the ER Cass Award from ACA, and the Bernard P. Harrison Award from the NCCHC. In today's conversation, we will explore her very much remarkable journey, the evolution of juvenile correctional health care, and the future of medical services in these environments. Dr. Staples-Horne, Michelle, welcome to this podcast. Dr. Keller, Jeff, will start our interview with our first question for you today.
Hey, hi, Michelle. So the other day you were talking to me and you told me how you came to get into medicine and how you came to get into juvenile medicine, juvenile corrections. I was fascinated. I thought it was a great story. Would you mind sharing that?
Sure. And first of all, thanks so much, Jeff and Susan, for inviting me for this podcast. I'm very excited. I'm of the older generation, not necessarily kept up with the technology to know podcasting and all the other modes of communication these days. However, I appreciate the invitation to really share my story. And Jeff, as you mentioned, my route was very, very unconventional. So I started out actually, grew up in the inner city, Atlanta, and went to public school. I never was exposed to sciences during those days. They weren't particularly encouraging of girls doing a lot of science. So I focused on English and on also language arts. And I was a journalism buff with the newspaper and photography, et cetera. So I was our high school reporter and actually received won a scholarship to attend Clark Atlanta University on that scholarship. And when I got to the first year, really the beginning of freshman year, I found myself somewhat bored with mass communications because we had been going during the summer and on weekends during my senior year. So I wanted to find something more challenging and exciting that I could surely get a job when I finished. So I saw the pharmacist when I was filling a prescription for my mom, and I said, oh, that looks like a very stable job, so I will do pre-pharmacy. But little did I know I was going to be thrown into physics and chemistry and advanced biology and all those things that I had not taken in high school. But much to my amazement, I discovered that I actually had an aptitude for those courses and did so well until I was able to get a scholarship for the next several years, actually through graduate school as well, for biology and chemistry. So I continued with that, wanted to do research because that's what I'd been doing. I would do research in between classes. And then I worked at night as an accountant for old Kmart, which nobody remembers where it came, but it was a large mega store like Walmart back in the day. So I did their books at night. And that came in handy later on in the job that I was to have. And I went ahead and I finished with my graduate education, did a biochemistry research thesis, and went to work at Morehouse College to work in the lab. But I soon got bored again. So I could not figure out what I could do with these graduate degrees in science until I remembered my food microbiology course that I had taken. And my professor, Dr. Rena Jones over at Spelman, had mentioned the the food inspectors in New York. And I said, oh, that sounds really interesting. Maybe I can use a little bit of food micro with that. So I went to work as the first Black female health inspector for my local county, DeKalb, and stayed with them for several years as a health inspector. Asked them to become a health educator because people did not understand the reason I was asking them to do the requests that I was making with regard to sanitation. So I worked as a health educator and then got involved more in the administrative capacities of the health department, and then found the job that I really liked. And it was this thing called population medicine. And the health director over our county had such a broad scope and influence over all the health of those constituents until I said, oh, wow, that's what I really like to do. Because my only experience with medicine was a private practice in the office, which to me, of course, I'm sort of, I like to be out and connect. So that was not going to work for me. So I went ahead and but the only challenge at that point was I had been out of graduate school 8 years, and I had been married, divorced, and now I had a 4 and a 2-year-old. So as things would go with me, I don't understand the word no. That's what my mom told me from years ago. So I decided I would go to medical school anyway. So I went to medical school with a 4 and 2-year-old, and that's a whole nother chapter unto itself. But I was successful with that. I actually married again and had another child at the end of medical school. And when I finished all of my training with peds and preventive medicine, I came back to Atlanta and I was looking for a job. And I ran into one of my professors again at the bank. And she said there was this new agency that had been formed a couple of years ago, and they were looking for a medical director. So she gave me one of the persons in the agency's card, and I called her and I set up the interview. And I found out later that the position had been advocated for by the Georgia Academy of Pediatrics for the governor to provide funding for the position. And the caveat was that the person hired had to be hired jointly by the commissioner of the agency at that time and the president of the Georgia AAP. So I interviewed with both, and actually they agreed upon hiring me in the position. The other part of this is the position was only good for 1 year. It was a grant. And they only had one secretary as my staff person. I had 24 facilities, and but I took the job. I stepped out on faith, and I took the job, and that was 31 years ago. So shortly after taking the job, they found a need for me because we had gotten a complaint from one of the attorneys from one of the facilities. And I was able to respond to the complaint and also write policy. So again, all these things sort of came into play because remember, I'd been a journalism major. I could write the policy. I'd been a health educator, so I could train the 4 nurses that I had. I had also worked as an accountant at night, so I could do my own books. It a perfect job, of course, the clinical setting and then the Master of Public Health. So I was able to really take that job and move forward with it to build that system into what we have today. And so I'll talk a little bit more about some of my past episodes that have led me to do this challenging job as well.
Michelle, providing medical care to incarcerated youth is a specialized and often under-recognized branch of medicine. What have been the most profound challenges and rewards in your experience in working within Georgia's juvenile justice system?
The greatest challenge was helping people understand that the health needs of these youth and this population should not be associated with their juvenile offenses. And people tend to want to label a child for the offense rather than looking at them as a child and looking at their health needs. And so that disassociation between the offense and the care of that child is critical. So I try not to have my medical staff even know oftentimes what the offense is, because we really need to treat our kids as children, treat them to the community standard of care, and realize that they have a lot of unmet health needs when they come to us. Even though people may perceive that they are healthy enough to be out getting in trouble, that's not always the case, because we have found a lot of children with very serious medical conditions like cancers, et cetera. But beyond just being able to diagnose a chronic and treat a chronic medical condition, we offer the preventive services for that youth, and particularly screening, which is really, really important, because for my own personal story, when I was 5 years old, I was hit by a motor vehicle, and it's because I really could not see the car. We roll along from kindergarten. I get enrolled in elementary school, and I'm a poor performer. But during those times, they really I don't think they had a lot of standardized testing, et cetera. So I just sort of was put in the back of the class, and they went on. In third grade, the public health department showed up to do vision screenings on all the kids in the school. And we all lined up, and when I got to the front of the Snellen eye chart, I could only see the large E, and it was not clear. It was quite fuzzy. So I was identified as needing glasses, and when I got my first pair of glasses, it was the first time in my life I was able to actually see the leaves on the tree. And it was amazing, because you don't know what you don't know. And so once I got my glasses, I excelled in my schoolwork. And I think often about our kids, that if no one does that screening, if no one recognizes that they have visual challenges, or that they have some hearing impairment or whatever, that may end up like I was back at the back of the class. And if I had not been screened and diagnosed and ultimately treated, then maybe I may have ended up in juvenile justice as well. So it's really important that we do the things that we do, and that we provide the preventative services for our youth as well.
So, Michelle, in correctional medicine, we physicians often have to navigate a complex ethical landscape. We have to, kind of what you just said, we have to balance patient-centered care with institutional policies and public safety considerations. How do you reconcile those demands while ensuring the dignity and well-being of your patients?
What I've always tried to do, Jeff and Susan, is really have that tight communication and collaboration between security and medical. When I first started this job, I made it my business to go out to every facility, to sit down with the security administrative staff, to always try, first of all, to learn corrections, because we didn't have any idea when we started all the rules and the nuances that were required. And it helped to look at standards and what was out there in the public domain. But the biggest thing, I think, was that collaboration between security and medical, because one cannot function without the other. And then even in my role today, if there is some type of dispute, I have it written into policy that it comes up to me when it regards medical care and security and medical cannot agree, then I'm the quote tiebreaker. And I've always been able to look at what the medical needs and the security needs are and merge them. I'll give you a quick example. We had a young man that came in that required CPAP. Well, as you know, we don't have electrical outlets in the cells so they were calling me, well, what are we going to do? This kid just can't get CPAP. I said, no, we have to find out a way for him to get the CPAP machine operational. So we were able to utilize the common area where we have the television set up and run extension cord up to the outlet on the TV and set up a privacy screen and have him set up that way to have his CPAP going at night. So the things of the give and take and the adjustments, but the ultimate goal is to provide the services and the health care that the kid needs while maintaining the security and the safe environment.
Michelle, preventative health care is particularly critical during adolescence, yet it is often overlooked within the justice system. In your experience, what role can juvenile correctional facilities play in fostering long-term health and wellness for these vulnerable patients?
I think that the strong reentry initiative that we have started, I guess probably now about 6 years ago, is really going to be helpful to our youth when they're released, and certainly other agencies. I encourage them to do the same thing. Many years ago, when kids would come to me, and I know a couple of examples, again, one youth got released and the nurse told them to have the mom go back and to the pharmacy and get the rest of his medications for him to complete. And he shows back up a day later and says, well, he violates probation to get back in, and says, well, my mom wouldn't get my medicine, so I just violated probation and came back for you all to give it to me. So we had a lot of kids that were actually coming to us for healthcare. And I even had some Master of Public Health students do a survey one year to determine where youth go for healthcare. And they identified DJJ as their primary healthcare provider. Despite me listing public health, primary care provider, STI clinics, emergency rooms, etc., they identified DJJ as their primary source of health care. Well, that should not be the case, because virtually all these kids have access to Medicaid when they're in the community, but we need to figure out how to get them connected to those services, and not just health services, all the other services as well that they need to be successful when they get back into the community. So the new initiatives with regards to trying to get kids eligible for and back on Medicaid before they're released is going to be very helpful. But I think we need to go beyond just healthcare and look at all those other social determinants of health, and look at education, look at the home environment, all the other things that need to be addressed in order for them to be successful and not return to us.
Well, yeah, just as like you were talking about, the transition from being incarcerated to getting out is a pivotal moment for the healthcare, especially for those kids that have serious health needs. What do you see as the greatest barrier to continuity of care when they go back into the community? And what can the medical community outside of corrections do to help these kids?
Yeah, the largest barrier or greatest barrier that we've had in the past has been the lack of insurance. Because as you may know, probably most people on this call know that when you become incarcerated, you're losing your access to Medicare, Medicaid, and other insurance benefits. So when our kids were incarcerated and lost their Medicaid, they could not get back on Medicaid until they were physically out of the door. And that depended on a parent, first of all, having a parent, which a lot of our kids, may have been in unstable home situations. It required you to have electricity, a computer, someone that can navigate the computer, all those things in order to get your application back into the Medicaid system. And then there's a whole process of determination, et cetera. So in the meantime, you may have run out of your psychotropic medications. There you are, right back at risk of being reincarcerated, or you had a chronic medical condition, you're diabetic, et cetera. You can't get your medications, you end up in the ED. And then there is an additional cost to the child as well as to society for having to or not being able to maintain that care when they're released. So the new requirements that started for juvenile justice involved youth January 1st will hopefully allow us to get the health check or the EPSDT screening done before they leave, identify, get them back on Medicaid before they leave, identify a primary care provider, and also provide some case management and substance use treatment if needed.
Michelle, the future of juvenile correctional health care may rely heavily on interdisciplinary collaboration. How do you see the roles of physicians, social workers, educators, and legal professionals evolving to create a more holistic approach to care?
Yes, the requirement, the new Medicaid requirement does require what we call case management. And the true case management takes all of those factors into account in order to make that child successful. You cannot send a child back out into the community, into the same community that they came from without any additional resources and expect a different result. So we have to be able to look at that child on an individual basis and identify the needs that they have when they're released and be able to address them. So we have developed things in our agency such as we do case management really when they come in, but we formalize the process 90 days, starting 90 days before they're released. The largest part of that is that we also include parents in that process because they play a critical role. And that was one quote, good thing that did come out of COVID. Prior to COVID, we were requiring parents to be in person, to come and meet in person. But during COVID, since we had so many visitation restrictions, we started allowing video conferencing, and participation shot through the roof. And so we've continued to do that because that way we can get the parents involved in the process and be able to not only meet the healthcare needs, but we look at education. We are a school district in Georgia, so we're able to get kids back into their school district, and if they can't get in their school district, then we have what we call educational transition centers across the state where they can go there and actually get not just a GED, but a high school diploma as well. So we try to address everything. And one other quick program, when we have, because of course we have a lot of kids with gang involvement, if we determine that, and they go through the process of wanting to get out of the gang and go through our behavioral program for that, then the health, we actually pay for tattoo removal. A lot of times the tattoos are, on the face or the teardrop or someplace visible. And so we're able to remove those for that young person. So when they do go back out into the community, they're not immediately tagged as being identified with that gang.
Wow, that's great. So if you had the opportunity to introduce one reform in juvenile correctional health care or two, what would it be?
Okay, so my suggestion would be to swim upriver. Like the old saying says, rather than trying to catch the bodies downstream, to go upriver and try to keep folks from being thrown off the boat. So if we can intervene with families early on, and, I've been told many times that's, quote, not our job in juvenile justice, that we have to wait until they become involved through the court system before we can really do a lot. But I really feel like if there was a way for us, or maybe in collaboration with some other agency, to go upstream and help these families that are struggling with all the things that lead to juvenile delinquent behavior. They may not have a stable home, or housing. They may have marginal education that's being provided. Parents may be working. It may be a single parent. It may be two parents in the home, but the supervision may not be there. So if there was a way to do that, and I have this very radical idea of how to do that, what I would like to do is extend the school day into a school year, into a possibility even overnight school, because so many kids, first of all, the only safe place they have is at school. It's not safe at home. It's not safe in the neighborhood. The only safe place they may have is actually in school. And then the other part of that is we have so many kids that are nutritionally deficient. They don't get food when school is out. They depend on the school lunch program for all of their meals. So in the evenings, they may be hungry. Certainly during the summers, they live in food deserts. And so the ability to feed them, to give them programming after, now the school day could possibly still end at 3, but they would have those after school activities that were supportive, such as assistance with homework, athletic participation. Because nowadays, in order to participate in athletics, your parents, first of all, have to have the $50 or whatever it costs now to get a physical exam for you. Then you have to purchase, even back when my kids, I guess 30, 40 years ago, when they were participating in school, I had to buy cleats. I had to buy the megaphone for my daughter. You have to buy sheet music, instruments, all those things. Most parents cannot afford that. Fortunately for me, when I was in elementary school, my parents could not have afforded an instrument, but the school had instruments. So I was able to join the band and play, and it taught me the discipline that I needed, that I think has carried me through my current career and all the others, because that structure was there. So those are the two radical ideas that I have. And along the same lines with the school, the teachers can still go home at 3, but we would train parents to be those caregivers in the after school hours. And that would do two things. That would provide supervision for the kids, but it would also teach parents how to be better parents, because no one has taught them. And that would be an opportunity for those parents to come in and get some training themselves as well.
Wow, good answer.
Very good. I really like that too. Yeah. So we're going to lead into your time as one of the presidents of the American College of Correctional Physicians. The American College of Correctional Physicians has played such a crucial role in advancing education and policy and clinical standards in correctional healthcare. And your rich experience in juvenile healthcare services in the correctional environment, I'm sure, has really transformed so much of what ACCP is today, has played such a pivotal role. So I ask with the most humble fashion, and what do you consider is the most significant contribution to the field of correctional? And how did your presidency help shape these advancements?
Okay, that took a little thinking. We'll take a little bit of thinking, because it's actually been 15 years ago since I was president. And during that time, I mean, the agency, I'm sorry, we were first the Society of Correctional Physicians. So we had not even changed our name to the American College of Correctional Physicians during the time that I was president. And that was in 2007 to 2009. So we were still a very young organization. I remember a lot of the founders, fortunately, that were there at the beginning of my participation with SCP. And I'll tell you one thing, when I went to my first SCP meeting, I can't remember the exact year it was a little intimidating for me, because I did see a lot of folks that looked like me. You know, it was heavily male, heavily white. And so I was really a little skeptical about joining the organization and felt a little bit uncomfortable. But I'm telling you, boy, the docs that were there, they really embraced me. They helped me with all of the programming. Ron Shansky, I can't say enough about him. He recently passed, but he came to Georgia as one of our monitors for the Department of Justice. Joe Paris was here in Georgia. So those folks really, Shelton, both Steves, all those folks were really, really welcoming to me. And so when I decided I would try to be president, I wasn't so sure if, everyone would feel like a juvenile person would be the best person, because usually I'd be the only person there for juveniles. And we're still working on that. But I was elected, and I think during my tenure, we really just tried to build up membership. And also, I think we did a lot better with our educational programming. Those have been my two most aggressive platforms during the time that I was there. But we were still very young. And, we were like any 15-year-old, we were finding ourselves. And we were attached at that time to NCCHC, that we actually were attached to their meetings. So we've grown up now. We're independent and we're on our own. And I support all of the presidents that have gone forward, including you, Jeff, because I see great things ahead for the organization. I'll talk a little bit about the carceral fellowship a little bit later on, but I'll let you get another question in.
Oh, well, okay. Well, that's kind of what I'm going to ask, but correctional physicians don't work in isolation. We work in collaboration across disciplines, agencies, and policy arenas. We all come from somewhere else. I was an emergency physician. We've got family practice physicians like Dr. Rashid. We've got pediatric physicians. How did your leadership at ACCP enable you to foster these relationships and incorporate these various groups into one organization?
I think because I've never really been good about staying in my lane. So I was involved with everybody's organization and pretty much still am. So I was able to bridge, I think, a lot of the gaps between the multiple correctional health organizations and the other medical organizations, at least as a start, because we were not seen, I guess, as large as the other organizations that have been around for many more years than us, but we were just as important. And so my ability to make those connections. So even though you may have had a correctional physician that was a part of another organization, when I went to that meeting, I recruited them for ACCP, and I still do that now. So whenever I went to any other venue, any other organization, if I found a correctional physician, I've gone to my medical school alumni association meetings and discovered that someone has moved over to corrections from whatever they were doing, family practice or whatever, in private practice, and they're now working in corrections. I get them into ACCP and I get them connected with our organization. And that's how I've done it all along, and still continue to do that, because it's really one patient. And it doesn't really matter what organization you're affiliated with. All the organizations should have the focus of the patient as their primary objective of providing the best health care.
Right, exactly.
Michelle, throughout your distinguished career, you have mentored and educated and shaped the field of juvenile correctional health care. It's so impressive, and I'm just in such great admiration of all that you've done for this field. So as you reflect on your journey, what do you consider your most meaningful professional achievement?
I think my most meaningful professional achievement has been to be an advocate for my kids. And that's advocating through presentations, advocating by finding mentees, by finding anybody in the organization is willing to listen to me, to really advocate for this population. That's really what I do. And that's the joy that I get out of this quote job, in that I feel like I'm doing something for the kids. And we have a culture wheel in our agency. And one of the spokes in the culture wheel is do the right thing. And as long as you do the right thing, I think that you will be successful. And you add to that a little bit of faith, which I've always had, because a lot of the challenges along the way and a lot of the jobs along the way and the things that need to get accomplished, the only way I believe I was able to get them done was to have some faith. Just like with, going to medical school with 2 toddlers, you got to have faith to do that. So the challenges that I've run into, I've always had a lot of faith that we could get them done. And we just really, that advocacy, I think, is key to having, letting people know what you do, because they don't always know what we do. And if we don't tell them, then they will be unaware of the needs of this population. And it's really a hidden population. No one really knows, other than what they see on the news. This kid just did X, Y, Z, but they really don't know what happened to that child before they got to that point. And oftentimes they don't care what happens to that child after that point either.
Right. Well, that's the thing, is that you have to develop a compassion in order to do our job. You have to develop a compassion for this population. It's often overlooked. And what do you think has sustained you in that? And when did your thinking about incarcerated people change over the years from when you first walked into a juvenile center 30 plus years ago?
Yeah, I don't know if it has really changed, because as I mentioned, I grew up in the inner city, and I knew, some of my classmates that got incarcerated. It was not a unusual thing to be associated somewhat, or be aware of corrections, especially with the overrepresentation of minorities that are incarcerated. So I was always aware of that possibility. I did not know anything about kids and juveniles because actually, I take it back. There was one facility that kids would talk about going Alto. Yeah, that was in the Georgia juvenile location at that time. So we would always talk about kids that were being sent to Alto. But I didn't really see myself as a physician at that time. And so I really did not, it sort of, all this has evolved over the years. And I think, as I mentioned, having that faith and that satisfaction in doing the right thing has really kept me in this position, because I have served under, I lost count, but I believe it was 16 administrations over the years. And every time the administration would change, I believe that I was kept in place because I was always taking care of the kids, and I was always doing the right thing for them and focusing on them, and also working closely with administration and security to get things right. So the policies that I wrote, I did not do them in isolation. I had, very early on, we would have these terrible policy committees, not only terrible because they lasted forever, but we would hash out what all the policy requirements were. And we not only had medical folks in there, me at the upper level, but I had the line staff, the nurses that were going to be on the floor sitting in the meeting, the directors, administrators, everybody that had some part of that policy, food service, if it was related to food service, everybody had some input into that policy because you want it to work. And I can happily say that those initial policies that I made are pretty much still in place, because I wanted to make sure everyone had adequate input and that it was something that was doable. The worst thing in the world you can do is develop some policy that no one can comply with. And if they can't comply with it, then you're going to have all types of problems and issues, because this is written for a reason. It's written to keep the kids safe, or written to keep them healthy. And so I think that the knowledge that what I have done so far is still standing and still lasting, that our electronic medical record that I set up with the programmers in, 1998, we're still using it. It still works. We're doing some enhancements, but the basic model still fits for what we've done. So what has sustained me is that my knowledge that this is something that has been built soundly, and that it will still be of benefit long after I'm gone.
That's great.
Michelle, correctional healthcare has long existed on the periphery of mainstream medical education and practice. What steps do you believe are necessary to elevate its importance within medical training, academia, and healthcare policy discussions?
Yes, that is so true, because we've been sort of the stepchildren of medicine for many, many years, because, historically, individuals that provided health care in jails, prisons, et cetera, were usually residents of that facility themselves, or other persons that were housed there that may have had some medical knowledge, and then maybe some that didn't, but just had the ability to barter for a Band-Aid. So we had a terrible reputation, and I think that has changed over the years, mostly because of ACCP and how we have started to credential and expand the knowledge of individuals about what correctional physicians do and how we are credentialed. But most recently, as of this year, the ACGME actually has released a carceral medicine fellowship. I've been fortunate enough to participate on that advisory council. And what we did, it's not that medicine is any different. Medicine is the same whether you're practicing it in the correctional environment or down the street. It's the other nuances that someone needs to train you on if you've never been in that environment. Security concerns. You can't lie an ink pen down or a paper clip down and leave it unattended. The relationship between security and administration and medicine and medical autonomy, and explaining those things to individuals that have never worked in that environment. So we took a very long time to try to tease out those things that a fellow, this is beyond residency, but a fellow would need to know. If they're interested in working in a correctional environment, then that fellowship is available to them for them to get the training that they need. And so we're working now to get relationships between residency programs and correctional facilities in order to train individuals that are interested in this fellowship.
Well, I have a question relating to that. Dr. Rashid did a fellowship, right? Is
Yes.
that the same fellowship?
It's beyond now they were the only fellowship in the country forever. But now this is the opportunity for other schools to develop fellowships.
Okay. It's expanding.
It's expanding because it's sitting under ACGME. So pretty much any credentialed institution has the ability to sign up and meet the criteria to have a carceral medicine fellowship. So I'll be presenting at some other conferences, and also planning on doing a newsletter for core docs to explain more about that program. But I'm excited about the ability for these young residents and even to get young medical students excited about correctional medicine and get them exposed to it. I've done mentoring. I had kids, I call them kids, sorry, students come in to our facilities to see what correctional medicine is like. But this will be a structured program that will expand across the country and hopefully get us lots more physicians interested in working in correctional medicine.
Oh yeah, that's great. That's fabulous. What do you see as the future of juvenile correctional medicine? What's your greatest hope?
Gosh, well, my greatest hope that we will continue to recruit excellent providers that are interested in the care and health of those individuals that are incarcerated, that they do not treat our patients as an inmate, that they treat them as a patient, and that the community providers see their role in coming into the facility and working with patients before they're released, and to be able to continue that care when they go out. And also just that I'm hoping also, and that this is probably a big hope, but one day there will be one electronic medical record that everyone will be able to use, that everyone can access. And so when youth or adults come into a system, a correctional system, we can pull up what is being done in the community. We'll be able to enter information in without, of course, disclosing the location, and be able to send that back out into the community and have that really true continuity of healthcare for those individuals and improve the health status of those persons that we interact with in correctional medicine.
Yeah, that's great.
Wonderful. Jeff, is there anything else that you would like to add in our podcast interview today with Michelle?
Yeah, I have some other questions.
Okay.
One of the things so in my career, I did some juveniles. So I had jails, but I also had juvenile detention facilities, and I also worked at the state juvenile prison. Your facilities, are they all detention facilities? Are they prison facilities?
We have a mixture, and I believe we may be the largest juvenile system in the country now, because we have 25 secure facilities. And so 19 of those are detention facilities. And all the facilities are spread out across the state. But keep in mind, Georgia has 159 counties. So the counties do not provide any locked facilities for young people. They all come to the Department of Juvenile Justice facility. So some of those kids that come to us are not, they're pre-trial, but we have what we call like catchment areas. So there may be one detention facility, and we call them regional youth detention facilities, centers rather. They may cover 8 or 9 counties in a small part, a rural part of the state, whereas we may have 1 or 2 counties covered by one of the larger facilities. So we do everything in Georgia. We have probation kids, we have residential placements, we have the youth that are in regional youth detention facilities awaiting pretrial or awaiting placement. And then we have the long-term secure youth that are in the facilities, which we call youth development campuses. Now, the advantage of that is that there is one medical system. And everyone, the upside of that is when kids get placed at a detention facility, we begin their medical record, but it's electronically transferred to the long-term facility when they get to the long-term facility. What we've not been able to do so far, because our electronic medical record was created before HIPAA, so a lot of the electronic requirements are not there around privacy, so we cannot connect to another EMR out in the community. So that's been a challenge of trying to get records out to young people in the community. So we're looking at some other mechanisms that we can do that. But one of the things that we do is have that reentry meeting so that if there's a specific medical need, that we get that appointment, or try to get that appointment connection made before they leave. And then we have some paper that we're still utilizing, discharge summaries, et cetera, to be able to send out. But it's a huge system, and we have 1,000 kids on any given day with those turning over in the detention centers. And I think we have maybe about 3,000 or 4,000 kids that are out on, it might be more than that. Anyways, a lot of kids out on probation and in the community that we're serving.
Wow.
I have an additional question for you, Michelle.
Yes.
When I started correctional medicine, I started with incarcerated adolescents. So that was my beginning chapter of going into correctional medicine. So it was girls and boys between the ages of 12 to 21. And I wanted to ask you, what would be the top medical issues that incarcerated adolescents have, and the top mental health issues? Because from my experience, I saw a lot of skin-related issues for girls, menstrual cycle-related issues, pre-diabetes, high cholesterol, obesity. And then I also saw on the mental health side, the depression, the PTSD, the trauma of being abandoned, and so forth. So I wanted to just gain your perspective, since you've been doing this so much.
Sure. Absolutely. So my preference has always been working with kids. I mean, I love them. And I love teenagers, because even as I was medical director for the Department of Juvenile Justice, I saw teens in the community for public health. And often the areas that I had my clinic were in the same areas that we had high prevalence of kids coming from. So I was always quite pleased. At that time, we were still providing pelvic exams and PAPs. So I was very pleased when a young lady, I asked her when had she had her last PAP, and she told me it was at she named one of my facilities when I saw her in the community. So that really made my day. But as far as needs, to be honest, the biggest medical need of these kids is dental. Most of them have never seen the dentist since that initial screening that's required when they come into elementary school. So no cleanings, cavities galore. The biggest, I would say, quote, health need across the board is dental care. And we have a huge dental program in addition to behavioral health that falls within our system. Behavioral health, PTSD, as you mentioned, number one, because all these kids have been traumatized in one way or the other. If not physically, then certainly emotionally traumatized and on multiple levels. And that's why I made that statement earlier. If I could go upstream and try to prevent some of that trauma and stabilize some of those families, then I feel like we would not have as many youth coming to us if we were able to do that.
Wow, that's great.
Jeff, do you have any other questions?
I don't.
A good conversation with you, Michelle.
Thank you so much. And I look forward to continuing working with ACCP and here in this position, maybe a little while longer. But I have really enjoyed the journey and the ability. Like I said, I feel like I've really accomplished a lot. If I think about even with our immunization program and how many immunizations we've been able to give, and how many people that maybe if they end up back in the system, and maybe even if they end up with HIV, they won't have hepatitis B because they would have been with me and I would have fully immunized them. So
that's great.
Yeah.
Michelle, it has been an absolute privilege to have you with us today. Your dedication to correctional medicine, particularly in championing the healthcare needs of incarcerated youth, is both inspiring and transformative. Your leadership has not only elevated the standard of care for some of society's most vulnerable populations, but it has also set a precedent for excellence in juvenile correctional healthcare. On behalf of the American College of Correctional Physicians, ACCP, and our listeners and viewers, we extend our deepest gratitude for your invaluable contributions and for sharing your valuable experience with us today. Your work serves as a profound reminder of the essential role physicians play in delivering compassionate, evidence-based care in the most challenging environments. We look forward to continuing these exciting conversations with our esteemed healthcare leaders and professionals in the field of correctional medicine. Stay with us as we explore more insights from the brilliant minds shaping the future of correctional medicine. Until next time, thank you for listening and tuning in.
Thank you.